Medication management is important, especially in older adults. Medication is one of the 4 M's of the age-friendly health system. Medication management touches us all and requires a complete team effort. It takes all disciplines and settings being actively involved to safely use medications in a patient and family-centered approach. We all have a role to play. This is important to keep in mind. Let's review the 4M framework of the age-friendly health system. The 4M framework includes what matters: mobility, mentation, and medication. The focus of this presentation, utilizing the 4M framework, results in high-quality geriatric healthcare. It's important that all 4Ms be delivered together reliably with every older adult encounter across the continuum. Why is that? Each of the 4Ms are interconnected. For example, medication is connected to mentation. Medications can affect someone's mentation, and mentation can affect the ability to take medications correctly. Medications are impacted by mobility and can impact mobility. They can affect someone's balance and their gait. What matters needs to be considered in medication regimens. For instance, when to add or remove a medication. Implementation of the medication 4M in an age-friendly health system includes the identification of potentially unsafe medications, identifying opportunities to deprescribe, and making sure necessary medications are properly used and adhered to. There are also screening tools that can help with that assessment. The objectives for this presentation are to discuss impact of polypharmacy on older adults, identify high-risk medication classes that contribute to polypharmacy and adverse drug events, and review available resources to aid deprescribing efforts. Medication management is important because potentially inappropriate medications can lead to adverse drug events, which decrease our health outcomes, and can lead to unnecessary acute care utilization and costs. For example, a New England Journal of Medicine study, referenced on this slide, estimates that 100,000 adults in the U.S. aged 65 or older have emergency hospital admissions annually, resulting from adverse drug events. Almost half of those occur in the category of adults aged 80 or greater. 2/3 of these hospitalizations were due to unintentional overdoses. There were 4 classes of medications that were involved in 2/3 of these admissions: diabetic agents, anticoagulants, antiplatelets, and opioids. Other studies have found adverse drug events to be the cause of 3.5 million avoidable office visits a year and over 1 million avoidable emergency department visits annually in the United States. Studies, facts, and figures like these led a multidisciplinary group to create the National Action Plan for Adverse Drug Event Prevention. Since 2014, the National Action Plan has been the foundation for the federal government's response to adverse drug events, including their response to the opioid crisis. It uses a multi-pronged approach, focusing on high-impact targets in populations for aids that are common, clinically significant, preventable, and measurable. For our first polling question today, we'd like to know what you think. Question: according to the NEJM study on emergency hospitalizations for adverse drug events in older Americans, which of the following best describes the medications most commonly involved in 2/3 of these admissions? A. Antibiotics, statins, antidepressants, and beta blockers. B. Diabetic agents, anticoagulants, antiplatelets, and opioids. C. NSAIDs, proton pump inhibitors, antihistamines, and laxatives. D. ACE inhibitors, calcium channel blockers, diuretics, and ARBs. The correct answer is B. Diabetic agents, anticoagulants, antiplatelets, and opioids. A major contributing factor to adverse drug events is polypharmacy, which is defined as the use of multiple medications for practical purposes. We usually define polypharmacy as taking 5 or more medications, and this is not limited to prescription medications only. This definition should also include non-prescription over-the-counter medications and supplements. What makes older adults prone to polypharmacy? There are many factors that contribute to this. One is simply the accumulation of medications over time. When many adults hit middle age and begin to start taking medications in small doses to help with common chronic conditions, like blood pressure or cholesterol control, they often continue with them as long as there's not a severe adverse reaction to that medication. Over time, doses are increased, and additional medications are added to either help manage that condition or others. We see those medications accumulate as we age. We also end up with multiple providers as we begin to see specialists. This highlights the importance with these multiple prescribers of medication reconciliation and having up-to-date medication lists with every provider that's been seen. Chronic conditions have a major impact on medication load. According to the CDC, 56% of adults aged 65 and older have 2 or more chronic conditions, and almost a quarter of them have 3 or more chronic conditions. These conditions often require multiple medications to manage. One example is the multiple medications needed to manage heart failure. This is also true with diabetes, hypertension, and other chronic conditions. Finally, once a person starts on a medication, they often continue with it regardless of its effectiveness. This can be true for medication started as a standing order during a hospital or rehabilitation stay. A prime example of this is the use of proton pump inhibitors. Also contributing to polypharmacy is the fact that prescription drug use continues to increase at a rate that is not attributable to our aging population. We have more drugs available to us and more conditions to treat. We often hear there's an app for that on our phones, right? Where there's an app for anything that we need help with, it seems we can also say there's a med for that. When it comes to our health, it's really easy to default to using medications as our initial response to when some sort of treatment is needed. The study on this slide showed that overall prescription drug use increased 9% from the year 2000 to 2011. And during this study, they also found that those taking 5 or more medications increased from 8% of the population to 15% of the population. It's possible that the 2021 prevalence of those numbers are even higher than it was a decade ago. This same study showed 2 in 5 adults, aged 65 and older, take between 5 and 9 medications, with almost 20% taking 10 or more medications. More recent studies have shown that a 5 to 9 prescription range could be as high as 60% now, so we have even a greater number of individuals that are older adults who are meeting the definition of polypharmacy. Not all polypharmacy is bad. If medications are indicated as complementary and beneficial, then polypharmacy is acceptable. However, when we get into medication overload, this is when we see those unnecessary medications. And there are some different ways that we can categorize unnecessary medications. These include those that are never necessary. An example would be a medication that's prescribed simply just to treat the adverse effect of another medication, or the medication is indicated but not officially. The medication is being continued even though benefits that we intended to use it for are not working, but we never discontinue it. We also could categorize a medication as no longer necessary. It might have been necessary at one point in time, but is no longer necessary. Some examples here include statins in those that are older, as well as daily proton pump inhibitor use. There's a final category that we can look at with polypharmacy where these might be unnecessary medications. That's involving over-the-counter meds and supplements. We don't want to bucket this just with prescription medications, but we want to include everything that's being taken. It is these unnecessary medications that lead to a medication overload and can result in a prescribing cascade, which leads to an adverse drug event. There are estimates that the risk for an adverse drug event increases by 7 to 10% with each medication that's added to a regimen. When we consider that we have 60+% of our older adults taking 5 or more medications, their odds of an adverse drug event are quite high. What is a prescribing cascade? A prescribing cascade isn't as beautiful as the cascade on this artwork, but it can be just as dangerous. Those rapids can present some danger, and so can a prescribing cascade. The definition of a prescribing cascade is using another medication, not to treat a medical condition, but rather to treat the side effects of another medication. Here we see the prescribing cascade cycle, where a medication causes an adverse drug event, which then either is misidentified as an illness, which results in another medication being prescribed, which then leads to a potential drug interaction with that original medication, or another adverse drug event, which then gets us in this cycle again, where we are prescribing just to treat medication side effects. The cascade begins when, instead of changing the medication causing the adverse event, or instead of treating it at the root, we add another medication to treat the symptoms. We're avoiding that baseline cause. Over-the-counter medications and supplements are also a contributor to polypharmacy. It's important to obtain a complete medication history list, including over-the-counter medications and supplements. It's estimated that 50% of patients do not inform their providers of all non-prescription medications, and this can lead to adverse events. An example of this is ginseng's effect on blood sugar and potential for hypoglycemia. There's also a lot of considerations with over-the-counter cough and cold products, and their potential effects on hypertension and accumulation of acetaminophen when used in combination with other pain relievers. There's also warfarin and many commonly used supplements, which then can increase our risk of bleeds or our risk of clotting depending upon which way the supplement affects the blood-thinning properties of warfarin.